Good afternoon, everyone. It's my pleasure to welcome you all to this today's webinar on preventing TB transmission, practical airborne control across the continuum of care, focusing on strengthening healthcare facility, infection and control, laboratory biosafety, and safe certification of TB patients as non-infectious.
Can you hear me?
On behalf of NITRD, I extend a warm welcome to our esteemed speakers here and all the participants who have joined us today. I am Shima John, Senior Nursing Officer and ICN of NITRD. We are delighted to have with us a diverse group of participants, including doctors, nurses, laboratories personnel, microbiologists, and other healthcare professionals. We are truly honored and privileged to have an esteemed panel of speakers with us today. Dr. Grigory Volchenkov, Chair, ETTI, Dr. Anita Rani Kansal, Chief Nursing Officer, AIMS Rishikesh, Dr. Manpreet Bhalla, Consultant, Department of Microbiology, NITRD, and Dr. Gyanendra Mishra, Associate Professor, Department of Respiratory Medicine, IGGMC, Nagpur. Before we begin, I would like to request all participants to kindly observe the following webinar etiquette. Please keep your microphone muted throughout the session and unmuted only when you are invited to speak or during the Q&A session. Please use the chat box to post your questions during the presentation. We will address them during the discussion or Q&A sessions. Please feel free to share your questions too. Avoid multitasking and stay engaged throughout the session to make the most of this learning opportunity. Thank you for your cooperation. We hope you enjoy this webinar and find today's session and valuable. May I now respectfully request Dr. Upadhyay, National Institute of TB and Respiratory Disease, to kindly address the participants. We look forward to your inspiring words to set the tone for today's session, ma'am.
Thank you very much. Am I audible?
Yes, ma'am. You're clear. You're audible.
So thank you very much. And I'm really happy that the NITRD team and all the specialists here have taken this initiative. Talking about airborne infection control, laboratory safety, and end of TB transmission is actually very, very important. Not only is it important for biosafety point of view, but generally it is important for eco-safety and the entire world safety. And it's really heartening to see, and I welcome Dr. Grigory, Dr. Gyan Shankar, Dr. Manpreet Bhalla, Dr. Anita Rani, and Shima and the entire team and all the participants who have taken out their time to engage in this very important session. And I hope it's a very fruitful discussion. And with these few words, I hand over the mic to the dais.
Thank you, ma'am. Thank you, ma'am, for your valuable address and words of encouragement. Without further delay, let us begin today's session. I now invite Dr. Grigory Volchenkov to deliver his talk on NTB Transmission Initiative, Global Efforts to Prevent TB Transmission. Warm welcome, sir, and very good afternoon. Sir,
good afternoon.
Audible?
Yes, can you hear me?
Yes, sir. Yes, sir. Good afternoon. Let me introduce you first, sir.
Thank you very much.
Dr. Volchenkov is the chair of the NTB Transmission Initiative, ETTI, powering Airborne Infection Prevention and Control, a Stop TB Partnership Working Group, an independent consultant from Russia specializing in airborne infection prevention and control and tuberculosis control. He has extensive international experience in advancing evidence-based strategies to prevent TB transmission. On to you, sir. Dr. Volchenkov.
Thank you, Shima.
Thank you.
I would like to thank you for inviting me to address to auditory of this exceptional webinar for Indian auditory. And as a chair of ETTI, I would like to greet you on behalf of the core group members of this group. This group is an international group of experts in the field of the airborne infection control, TB infection control, and laboratory biosafety. The mission of the group is to advocate for and lead operationalization of policies and expansion of the evidence base through research, education, training, and scaling up effective implementation of airborne IPC. ETTI and full name of the group, as just Shima said, is NTB Transmission Initiative Powering Airborne IPC, is supporting the global fight against TB and other airborne infections by promoting development and implementation of feasible measures able to prevent and control the airborne infection transmission. It's very important that India is a very advanced country in this regard. This year, a couple months earlier, India approved and started to work using the new, very modern, the most recent international guideline on airborne IPC. I was involved somehow in the development. I supported that, and I would like to express my understanding that this is the most updated, recently updated national guidelines in this field. And it actually helped to reduce the risk of transmission, not only TB, but for pandemic preparedness of the country. And this is a very good example for other countries to implement such modern and effective measures. I would like to say that Indian colleagues, members of the ATTI, Dr. Manpreet Bhala, Dr. Anita Rani Kansal, and they are very active and very productive core group members. ETTI has a website, web page on Stop TB Stop TB Partnership web resource, which includes lots of materials which can be used by our Indian colleagues in implementation of the airborne IPC measures in the field. We have a regularly updated newsletter, and I just invite all the webinar auditory to subscribe to this newsletter and check materials in English and many other languages dedicated to the implementation issues of the airborne IPC. I would like to thank you again for organizing all this webinar. Thank you all of the Indian core members about your activity in the group. Wish you a great and useful webinar. Wishing you success. Thank you for inviting me to speak to you.
Thank you. Thank you, Dr. Walchenka, for such an excellent talk. We got to know much more things about ETTI. Moving to our next topic, airborne infection prevention control, practical implementation in healthcare facilities by Dr. Anita Rani Kansal. Warm greetings, ma'am, and a very good afternoon. Am I audible, ma'am? Are you there? Dr. Anita Rani Kansal, ma'am? She's there.
Yes,
A very good afternoon. A very good afternoon, ma'am. Dr. Anita Rani Kansal is Chief Nursing Officer in AIMS Rishikesh and Chairperson CNE Cell there. She has been recognized by the ICM TB MDR TB project as a leading light in recognition of her outstanding contribution to the care of people affected by TB, conferred by ICN Geneva, Switzerland. Thank you, ma'am. You can join. Now it's on you.
Yeah. Thank you, Shima, for the nice words. So today I'll just start with what all we can do for the airborne infection control. I would like to share my screen. Are you able to see my screen, Shima?
We are able to see you, ma'am, not your screen.
Yeah, but your voice is a little bit not clear. I think internet.
I think you are facing some internet connectivity issues.
Yeah, maybe little bit internet. But can you see the screen now? No.
Screen, ma'am.
Yes.
Can you see?
So clear.
Can I start, Shima? Can I start? Is it clear?
Yes, ma'am. Audible. Quite audible.
Okay. A very good afternoon to all the participants. I can see more than 100 participants and my core team members and Dr. Grigori and Dr. Upasna, especially those who have given me this chance to speak about the airborne diseases and how to protect ourselves or how to make the environment safe in the airborne diseases. So I will just, in the next 20 minutes, we will be mainly talking how practically we can change our wards or our units or our homes in a better, safe atmospheres. So airborne disease is any disease that is caused by the pathogen that can be transmitted through the air. So these diseases can be, as we know already, tuberculosis, COVID, whooping cough, SARS, influenza, diphtheria, chickenpox. So all are the diseases which the virus, most of the cases, the virus transmits to the air. So here the basically when the one is the source from where the virus will be transmitting and through the environment. Basically in this case it will be through the air and it will reach the recipient, and all these three factors are very, very important to see whether the infection occurs or not. So just if we see any cough dynamics or any air dynamics, whenever somebody speaks or cough, the large drops fast fall and the small drops, they will hang around. And those who are very, very, very less than the 1.0 micron, they will be into the air almost for 24 hours. So this matters that the larger drops will not be that much infectious. The smaller droplets or the smaller drops will be infectious. This is just to the studies have been done that the how much time the size of the droplet matters, that the how much time it can stay in the air, and that is the main root of the infectiousness. So just to see that how we can have a better airborne infection control. So ventilation is very important in this part. So what is ventilation? Ventilation is mainly movement of air, pulling and the pushing of the particles. That means preferably in a controlled manner, where the patients are there in the wards, where the TB patients are there, those who are coughing, and those who have the sputum production, those who are AFB positive. So they will be spreading lot of bacteria into the air. So we have to see that how we have to make that ward or that unit into a better airborne infection control. So ventilation is very important in those cases. So we have to see in next slides, we will see that how the ventilation and the direction of ventilation is important. So what is effective ventilation? Air exchange. Air exchange means this is the air exchange per hour. That means how many times whole of the air can be changed in 1 hour. That is basically air exchange. So minimum 6 air exchange is needed in any of the setting, in the normal wards or in the homes. But if the high risk setting like the wards, MDR wards or the ICUs, it has to be more than 12 air changes per hour. So the flow should be clean air in and the contaminated air outside, away from the patient care areas. So this is just again the ACH, that how many ACH will be able to remove any infected particle. So if the ACH, that means the air, only 2 air changes per hour. That means whole of the air is changed 2 times in an hour. Then we can see that it will take almost that many minutes to remove the 99% of the particles in that air. So more of the air changes, the better will be the ventilation. So that is the main concept by this slide, that the more will be the air changes per hour, the better will be the ventilation and the less chance of the infection will be there. So this is just the how the different areas are at the risk in case of TB or any infectious airborne infectious disease. The outpatient facilities are usually because the risk at the outpatient facilities are also is more because at undiagnosed patient, those who are still to be diagnosed are there. So usually in the general wards or the medical wards where the patient has been admitted and has been started on the treatment, that will be less infectious than the OPD. But we see emergency rooms also will be more infectious, and the laboratories, you can see the here in the blue, that is 78.9. That means the laboratories are at the highest risk because where the bacteria is isolated, they are grown into the culture labs and they are directly seen under the slides. That's why in this seminar, in this webinar only, Dr. Manpreet will be talking about all the safety measures that we have to take into the laboratory. And that is very specialized airborne infection control in the labs where the TB bacteria or any bacteria, viruses, those are airborne, are seen. So now we'll just talk about this few slides where that the how the what is the ventilation and how this ventilation is related to airborne infection control. Now after this, what are the fundamentals of or the what is the basic control of airborne infection control? There are mainly three types of airborne infection control. Number one is administrative control. That is the first priority. And the second is the environment control. That is second priority. We will mold the environment way that we have the more ventilation, by mechanical ventilation like that. Third is the respiratory control. Respiratory control is the third priority where we protecting the healthcare workers, like by giving them the N95, like that. So the administrative is of very so much of value that it is given at the first priority. What is the administrative control? So administrative control means transmission of infection, procedures for implementing, enforcing, monitoring, evaluating, and revising the infection control plan. So this is likely to have a greater, because here the policies are made. Like we have the TB wards, non-TB wards. So where the policy is made that the no non-TB patient will be admitted to a TB ward. No MDR patient will be admitted to a drug sensitive TB ward. So these are the policies which has to be made at the administration level, and that has the highest impact. So this serves as the first line of defense for preventing spread of tuberculosis in healthcare setting. It can be implemented at all levels of healthcare, whether it's primary, it's secondary or tertiary care. This can be used for both the inpatient and the outpatient areas also. It can be used for the outpatient areas also, how we will see in next slide. So basically administrative control means developing and implementing a written TB control plan. Please mute. Ensuring the availability of prompt laboratory processing, testing, and reporting of results, ensuring proper cleaning, sterilization, and disinfection. Like in the microbiology labs, there are so many of sputum vials, sputum samples, which are infectious. So treating them, making them sterilized, disinfecting them, that is very important. So policy on that how we have to do. Educating and training the healthcare workers, calculating, monitoring, air changes per hour, air handling units, change of HEPA filters. These are the things that can be done at the administration level, that when we have to change the HEPA filter, how it will be changed, who will be changing, what are the SOPs. So all these things are to be done at the administrative level. Patient education, sputum collection, triage, and evaluation of suspect TB. Triage is not only in the emergency, it has to be done in the respiratory areas also. Any patient, any in the general OPD, any patient coughing should be separated. They should be seen at the fast track or they should be kept separately. Reducing exposure in the laboratory, inpatient management and isolation policy, meeting or the discussion of gaps, regular meeting of the infection control committees. So how to implement, this was all the theory that we have talked about, how to implement the administrative control measures. Like in the OPDs, we can have the registration. At the registration, we can have the screening, and the screening, anyone who is coughing can be separated, or they can be provided a mask. This we had implemented at the NITRD, that all the OPD patients, even and their attendants, were given a surgical mask to them, so that at least uh, they prevent some level of infection. Fast track in the general hospitals, this is implementable, that those who are coughing, they should be either seen fast and should be sent from the public area, sent back early. Health education, that they should be using tissue and all, and cough hygiene. These are very, very important, because ultimately if we control at the source, that will be good to control. So these are just some of the posters that we have in our OPD at the NITRD. Then separate sputum collection area that keep the aerosol generating procedures away from patients. Even the bronchoscopy or all these rooms, they has to be separate, and sputum collection area has to be at a open and at a away from the IPDs or the OPDs. So these are the bronchoscopy rooms, suctioning rooms. They should have a special infection control. So segregation, that we keep the HIV and the TB patients safe, because previously in the NITRD also we were keeping the HIV patients and TB patients at the same time in the same wards. So ultimately, with this, that their TB patients are at more risk of HIV patients are at more risk of getting the TB. So a separate ICTC or ART center was developed. So these are all the administrative measures that we can take. Infection control policy, that is usually headed by the microbiologist, and it takes care of both the airborne and other infection control measures. And segregation, separate TB wards, non-TB wards, and MDR wards. This has to be done in the units, in the hospitals. Healthcare worker protection, that we had the policy of rotation, staff rotation in TB and non-TB wards, so that they have the less exposure, because we have seen the number of years of exposure in the TB wards is directly related for the probability of getting TB to healthcare worker. So the rotation policy was implemented. Policy of staff immunization, all the staff has been immunization against the HCV, and the regular screening. Annually, all the staff are screened for the chest X-ray and other tests, so that we can early detect the problem. Then regular training of the employees. So this was provision of mask to the OPD and the IPD patients. This was also done practically. This was implemented at the NITRD. Setup of a health education department. In NITRD, there is a special health education department who takes care of health education of all the patients in the OPD as well as in the IPD. Health talks regarding cough hygiene, nutrition, regular follow-up of the patients, nurses and the health visitors, regular fumigation of special units like dressing rooms, minor OT, ICUs, bronchoscopies, and the yoga facility for staff and the patients for better immunity and well-being. So now this was all that what are the practical administrative controls and how we can implement. Now we come to the environmental control, that how we can change the environment for a better ventilation. So basically these are reducing at the that how we can reduce the concentration of infectious droplet into the air, how we can reduce that. So this can be, the ventilation system can be natural, mixed mode, or mechanical. Mixed mode means you keep the windows open at the one side and put the exhaust on the other side, so that this will be the mixed mode. And the mechanical ventilation means you have a seal room with the specialized negative pressure wards, where the air is one directional. Air is there, air enters from the one part and it ends or it exits from the other part of the ward. So these are the natural ventilation is simplest, that we don't have to it is not expensive, but the only problem is that in the extremes of the weather, whether it's summer or winter, it becomes very difficult to keep the windows open. So the maximum natural ventilation through the open windows, open shaft, and the bed spacing, that can be done. So this is just showing that how single-sided ventilation, cross ventilation, and stack ventilation. So it seems the stack ventilation is the best, where we can see the air coming from and going at 4 places. So this is the directional control of airflow and the negative pressure room, as has been created into the MDR wards of NITRD, where with the condition the air will be at the positive pressure will be at the nurse's side, and slowly, and when you go into the ward, the negative pressure will be there at the patient bedside, and ultimately suction will be there. It will be exhausted from the patient head side to the outside with the HEPA filter. So that makes the patient as well as the staff safer. So this is for the better, always for the better air exchange. The partitions will always reduce the air exchange. So in such settings, we should not have the partitions. So this is now if the ventilation is there, but what is the direction of ventilation? That is also important. If all the air from a positive patient, from AFB positive patient is coming to the staff or to the doctor who is who is seeing in the consultation room or in the ward where the sisters are working or the nurses are working, so that is not the ideal situation. So only ventilation is not important, the direction of ventilation is also important. So in this we can see that the wind, if it goes from the healthcare worker to the patient and then it goes out, then it's a good. If it goes from the patient to the healthcare worker, then it goes out, then it's a bad. That we can see the clean air from staff side, it should go to the patient side. And sometimes if this is not feasible because already infrastructure has been made in the wards, so there is compromise like that, that the directly we are not getting the air from the patient side. It has to be some good compromise, like the third figure that we have seen, that the wind should be crossing, but one side should be the healthcare worker, other side should be the patient. So the limitations of natural ventilation, that direction control is not possible because we cannot make the air to move. In the natural ventilation, it will start, air can start in any direction, and extreme weathers make it difficult to keep the windows open. And mixed mode ventilation means that sometimes you use the ceiling fan. Ceiling fan will help in, it will help in mixing of the air. It will not help in like reducing the content or the reducing the infectious material, but it will help in mixing of the air, where the exhaust will improve the ventilation because it will exit the air from the room. So mixed mode, we can use the window, fan, exhaust ventilation system. So basic purpose of all this is to dilute or removal of the contaminated air. So limitation of the mixed mode ventilation, that is improper installation of exhaust fan. Most of the people, they'll put the exhaust fan on the window itself, which is not at all right. At that, in this, the air from the room will not be cleaned or will not be circulated because the air will be taken from the window and it will be exhausted at the window only. So size of exhaust, it has to be seen how much area of the room is there, whether that exhaust fan is adequate or not. And mesh cleaning and all this is also very important, whether we are cleaning that it has adequate space to move out the air. So in this we can see that the only at the windows, if we are putting the exhaust, this is not useful. This is also the same example. So in the mechanical ventilation means the use of negative pressure to control the airflow patterns in the patient or procedure room or the setting. That means we will, as we have done it in the MDR wards of NITRD, where the unidirectional flow of air is there. And we usually we make the log books whether how much negative pressure is there in the patient's rooms. So this is just a supply that how the air will be going from the nurse's side to the patient and it will be exhausted out. So mechanical ventilation, this is a more complex, costly method. We need to have engineers, we need to have log books, we need to spend a lot of money. So it's a very costly affair. So the next in the environment control that can be done, the UVGI. UVGI is the ultraviolet germicidal irradiation. So these are the additional to other measures that we can put at the at least where the patient waiting area like that, where a lot of people are sitting and they are likely to spread the infection. Here we can put the UVGI. So here you can see in that gives the light. This with this light, the bacteria, if comes into this touch, will be killed, and the air will be moving from down to upward, and slowly whole air can be cleaned. Limitation of UVGI, that its installation, its maintenance is very high, and it's not good for small wards. Then it also needs change of lights, and so many of other maintenance required separate staff. These are the UVGIs that has been put at the NITRD, and in the high risk areas like the bronchoscopy room, X-rays room, any room which is closed where the ventilation is less, UVGIs are being used there, or in the waiting area. MDR wards. This is the MDR ward, example of MDR ward in the unidirectional airflow, where the sister is sitting and she is looking at the cameras where all the patients are there. And from here, the positive pressure goes inside. So bed arrangements that we can do in the environmental, this thing, that those who are positive cases that we can put at the near windows, and we can monitor the ACH, whether it's. So these are rearrangements of furniture, many changing of wire. These are the actions that we had taken in the wards: regular cleaning of small ventilators, providing PP, exhaust systems, etc. So sputum collection area, it was from this closed environment to it was changed to a open area. This is open shaft in the OPD, which is also good for the air exchange. These are the UV lights. So to summarize the environment control, that we can have the patient segregation, bed spacing, effective ventilation, use of UVGI, and use of mechanical ventilation, use of exhaust fan, etc. Now the respiratory controls. Basically, this is the personal respiratory protection. It goes hand in hand with the administrative and environmental measures based upon the airborne transmission risk assessment. Imposing any filtering material in the respiratory path will remove or restrict the particulate or the aerosols. This is just the respiratory versus the surgical mask. Basically, the surgical mask, respirator should be worn by the healthcare worker, and the surgical mask should be worn by the patient. When we say if the surgical mask cannot filter the bacteria, why the patient will wear, or if the patient will wear, how does it going to protect? Because at least the surgical mask will be able to control the bigger aerosols from the patient, because ultimately when patient coughs, the bigger aerosol comes, and with the dehydration, that becomes smaller aerosols, and then it moves around in the air. But with the surgical mask, at least those bigger aerosols will not come out. So this was made a policy in the NITRD, that every indoor patient will be given a mask. So this is all respirators need to be assessed for the, it should not be loose as shown in this. This is, they have to be seen for the fit and seal. That is very important. N95 mask should be seen for the, or the respirator should be seen for the fit testing. So fit testing is very important. This is again a big topic that we can talk about, that how to do a fit test, qualitative and quantitative. This will not cover in this. So I think the healthcare workers, with this understanding, they can make a lot of changes, and they can make their environment safe. So these are all the summarization of that what we have all read. So this was all summarization of that we have done. So a very thank you to all of you for listening to this, and special thanks to Dr. Upasana Agarwal, director, for permitting for this, and Dr. Rohit Sareen, ex-director of NITRD, with whom we have started this airborne infection control journey, and all the members of this NTB transmission, ETTI, and International Council of Nursing, who are the ones who have taught us all this and given training to us. CDC at Atlanta, Echo India, those who are always support with us, and E-Niti moderator, CNE coordinator, Ms. Shima. She is always a support to us. Thank you so much. Any doubts? I think I can take up now only.
Thank you, ma'am. Thank you for that wonderful presentation. It was quite, you dealt with all the simple basic, and I think the language was quite easy to understand. Even the nurses, the lab technicians can also understand your language. Thank you, ma'am. I request all the participants to please use the chat box to write your queries so that you don't forget during the presentation. It might be that after the 3 or 4 presentations, you might forget what to ask during the first or the second presentation. So it's better. I request all of you to post your queries in the chat box when you are in the same presentation, when you are listening to the same ones. Thank you. Now, moving on to the next speaker, it's my pleasure to invite our next eminent speaker, Dr. Manpreet Bhalla. Warm welcome, ma'am. A very good afternoon too. She is here in the NITRD Eco Room, right extreme to me. Dr. Bhalla is a consultant in Department of Microbiology at NITRD and also a former HOD and director at NITRD. Ma'am is a member of NTB Transmission Initiative, ETTI, core working group of Stop TB Partnership and has a vast experience of 30 years in the field of TB diagnostics and member of Drug Resistant TB Committee. On to you, ma'am.
Thank you, Shima, for the nice introduction. And I'm audible. Am I audible? So I will today I'll be talking about the lab biosafety and the airborne infection control. So Dr. Anita has already covered the airborne infection control from the perspective of the hospitals, general hospitals. So I will not be talking about that. I will be talking about the lab part. So from concept to application in TB and beyond. So it is very important to protect the lab staff from microbacterium, tuberculosis, and other pathogens. So the environmental and administrative and respiratory controls, every lab has to run these controls. So as told by Dr. Anita, I just want to reiterate that for every setting in a hospital, the lab is the highest risk. So we can see that 78.6% is the highest TB incidence rate ratio in the laboratory workers compared to the others. Because as you can see on the right side, we do different procedures. We generate aerosols, but we do the culture, we do the DST, pipetting, vortexing, centrifugation, and you are expected, unlike a patient passes through the lab for some time, the lab staff has to spend full shifts in the lab and they are working the whole day. And facilities that implement AIC packages, so we need to cut healthcare infection sharply, which is a preventable risk. So first coming to the science of airborne spread to a lab ready action plan. So first is the how the TB travels through the air, the infectious respiratory particles, then the hierarchy of controls. So why the order of difference matters in a lab? Then Anita madam has talked about the administrative and environmental and respiratory protection, but I will be talking in the lab. So in the lab, the administrative controls include the SOPs, the standard operating procedures, the workflow, specimen handling. The environment controls are ventilation, the air changes for our biosafety cabinets, which we use in the labs, and the germicidal UVs. The respiratory protection, that is common for the N95 respirators, and we have to do the fit testing and seal checks before using these masks. And the most important thing is healthcare worker surveillance, training, and monitoring. The signs of airborne infection. So, what is the difference between AIC, IPC, and biosafety? So, the TB lab sits where all the three meet. So it runs the AIC measures inside the IPC program under a biosafety framework. So the lab is in the middle of all these things. Airborne infection control is the set of measures that we have all seen, which to limit the exposure. IPC is a broader program. It covers the transmission routes, contact, droplet, and airborne across a facility, and the lab biosafety. In the biosafety, we have to follow the practices, equipment, and facility design. that contains the hazardous agents while the staff work. And these are the practices which are applied in the lab. So this is again the same thing, AIC differences between AIC, IPC and biosafety. So airborne transmission is happening in healthcare facilities. Again, this is among the all the risk of TB inpatient facilities in all the areas. As you can see, the TB laboratories have the maximum risk, followed by the general medicine wards, emergency rooms, and outpatient facilities. So earlier we used to say that during the COVID time, you must have we were using these terms like droplets and aerosols. So there was a lot of confusion and it was not clear cut. So now the lab, the message is simple that we have to and these things which generate the particles expelled from the nose or mouth. When a person breathes, talks, coughs, sneezes, or spits, which can carry the TB or influenza, measles, SARS, or any of these particles, these are all collectively now called as infectious respiratory particles. So there's a single term which is used now. And depends on the size of the particle. The larger particles, they will settle faster and they cover a shorter range, whereas the smaller particles, they remain airborne for a longer time and they will travel further. The modes of transmission of respiratory pathogens, this is also the same. It depends on the distance. If it is suspended air carried by the airflow and inhaled, so it can go anywhere along the respiratory tract. If it is direct deposition, there is a short distance, then it will enter through the mouth, nose, or eyes. There may be direct contact through the touch via the hands, that would enter through the mouth, nose, or eyes, and indirect contact. This is any distance, so touching any contaminated or intermediate object, that is mouth, nose, or eyes. So for the TB lab, TB spreads entirely by the airborne route. Aerosols you generate can travel any distance and reach the deepest part of the colleague's lung. So any person who is not using this protection, we can transmit in the lab to these persons. So 5 factors that decide whether an aerosol infects. So which factors it depends? First of all is the host immunity. If the person has prior infection, vaccination, or immune status is compromised, they will be more prone. Secondly, how well the organism survives in the air, how long it remains suspended in the air, and the infecting dose. Third is the particle size. Smaller particle size, as I already told you, they remain suspended longer and they can penetrate deeper into the lung. The force behind a cough. If a person, a positive patient coughs and very forcefully, or if you are using a vortex in the room, and there are air currents in the lab and ventilation is not proper, this also can lead to the more infection. And exposure time, this is also important. Concentration in the air and how long you breathe it. So how long that person is exposed to those infectious particles. The chain of infection, so this is infectious agent, that is the MTB, reservoir is the sputum or the culture which we are using, the drug sensitivity testing plates. The portal of entry can be from pipetting, watering. Transmission is airborne. Portal of entry is inhalation by staff. And susceptible host can be a colleague who is unmasked and is not using. So AIC breaks 2 links. Biosafety cabinets and ventilation, they cut the portal of entry and exit, and respirators protect the portal of entry. So if you remove any one link, the infection cannot occur. This is again, I just want to tell you in the lab which areas are more infectious. The direct microscopy area is less infectious. The NAT and molecular area where we do the CBNAT or the TrueNAT, that is also because we are using closed cartridges. Where we are doing the specimen manipulation and aliquoting, that is processing the sample, opening tubes, pipetting, that is has a moderate risk. Then vortexing, sonication, homogenization, this has a higher risk. Culture and drug susceptibility testing, because we are doing handling of live bacilli is the highest risk, and centrifugation. So these all carry a very high risk. The hierarchy of controls, this should be applied in the lab also, and this is also important. I want to tell you that the 2010 guidelines were there for the airborne infection control, and now there are the 2026 guidelines. So, what is the difference between these guidelines? In the 2010 guidelines, they had established the three-tier model of controls. That is the same. This was fed into the NABH hospital accreditation, and it was broad audience, not lab specific. Whereas the new guidelines after the post-COVID, so as it unifies all respiratory pathogens under the infectious respiratory particles. Then there is a dedicated high risk setting chapter covering the TB labs, separate chapter. There are modern engineering measurable ACPH, GUV, HEPA guidance. These are all there in this guidance document, and formal healthcare worker TB surveillance and HICC rules. So these are all been well defined in the 2026 airborne infection control national guidelines, which have just recently been circulated. So again, administrative environmental respiratory, this is from the point of the lab. So in the administrative, we have to do the AIC plan, SOP, safe work practices, triage, training. In the environmental part, we have to ensure the ventilation, air changes per hour. We have to have biosafety cabinets, the germicidal UVs and HEPA filters have to be in place, and there should be a directional airflow. And from the respiratory point of view, we need to use N95 respirators, fit testing, and we have to do the correct downing. So this is in the administrative controls, the most important thing, and we have to follow this order. Administrative controls followed by environmental controls and respiratory protection. So first we have to stop the aerosols being created. Second, we have to remove the particles which are airborne. And third, we have to protect the individual. So never start with a mask. So a respirator is the last safeguard. Use because the first two lines cannot make. So if the first two lines of do not fulfill the requirements, then we have to go to the third, respiratory protection. So the three pillars, again, this is the same thing. In the lab, we receive the specimen, we prepare the specimen, we open the sample inside the biosafety cabinet, we do the processing, we do the sanctification. We usually do it in sealed buckets. And we vortex in the biosafety cabinet. When culture and DST reading is done, minimize the open handling, and the waste generated has to be autoclaved, and all the discard has to be put in 5% phenol and segregate as per biomedical waste management. This I've already told you. For administrative, we need to have SOP. For environmental, we need to have a room ventilation target, class 2 biosafety cabinet, sealed centrifuge buckets, the germicidal UVs, HEPA filters, and respiratory, we need to wear the N95 mask wherever we need to do the decontamination. This is the same, I already told you this levels. So there are different biosafety levels mapped to the TB procedures. First is the BSL-2 level, that is sphere microscopy and NAT. So here we need to have only hand wash sink, we need to have biosafety cabinet available, restricted access, biohazard signage, and PP. Then if you are doing a slightly more procedure which is more severe, so where we are doing the processing, we need a directional inward flow, we need to have a class 2 biosafety cabinet mandatory, sealed centrifuge buckets and N95 respirators. And then if we are going to do the culture and DST or DRTB isolates, we need to have negative pressure, anti-room, controlled entry, HEPA filter, and full respiratory protection. Administrative controls in the lab, we need to have SOPs, need to have a designated focal point. A person who is a biosafety officer, he or she is answerable to the facility, hospital infection control committee. There has to be regular risk assessment, the workflow design, access control, training and signage. So a lab AIC plan, every facility should hold. The plan has to be specified who is responsible, who is the AIC focal point, and how they report. The risk assessment findings, ventilation targets, procedures for implementing it, training schedule, and competency records. Once the AIC focal point and the hospital infection control committee, and supporting that is the laboratory airborne infection control biosafety focal point. What are the core duties of the focal point? To implement and enforce the AIC plan day to day, run and document the facility risk assessment, check the ventilation, biosafety cabinet, the germicidal UV maintenance records, and coordinate staff training and fit testing, and report incidents and quarterly indicators to the Hospital Infection Control Committee. So the facility and laboratory assessment is a structured plan. So the focus, we have to first assess how many TB samples that lab is receiving, what procedures are there in the lab, how many staff are exposed. Then we have to assess the air changes per hour, airflow direction in every working area, identify each aerosol generating step and its containment, and rank the gaps, fix the high risk areas first, and with a dated plan of exit. So use the facility risk assessment checklist and the ventilation monitoring checklist from the national guidelines. And again, we all know this, I think, very well, that it has to be a one-way workflow from clean to dirty. From the clean zone, we have to go to the dirty zone and not vice versa. So in the clean zone, we receive the specimen, we do the data entry, we do the reagent storage and reporting. Then transition to the next area where the downing is done, the PPE donning, the sample logging, and leak check whether the sample is leaking or not, and then go to the dirty containment zone, that is the biosafety cabinet, centrifugation, culture, and DST waste. So this is the flow, unidirectional flow has to be followed. So what are the do's and don'ts? So never collect sputum indoors, not in the lab, not in the toilets, not in the enclosed space. Dr. Anita has shown where we should collect. It should be collected in an open area, because the area where the sputum collection is done, that is the most infectious place. It has to be very well ventilated, and we have seen that air changes per hour, 12 air changes per hour are sufficient for most of the areas, but where the sputum collection is done, we need to have more than 20 air changes per hour. And there should be direct sunlight, it should be away from people, and there should be correct technique that has to be explained to the patient. The specimen transport, if the sample comes to us from far off areas, there is a triple layer packing where there is a primary container, secondary packaging, and outer packaging. So I won't go into the details. So we need to have this triple layer packaging. And we need to cut the aerosols at source. This also everyone is aware that we should do the least aerosol production and discard pipette tips gently, and you clean the surface with 70% alcohol before and after work. And work slowly, and never vortex sonicate in the open bench, never flame loops, never pour off supernatant in the outside containment, never recap needles, never eat, drink, or touch your face in the lab, and never rush a step to save a few minutes. Signages are very important. We should have signages, control access, restricted entry, where only trained staff can go, clear biohazard markings on the doors, posted wherever there is high risk areas, cough etiquette, and competency is very important. Induction training before independent work. Any new staff joins, we have to do the induction training before, annual refreshers and fit test renewal, and assess compliance. Keep dated training and competency records. So this is just the pictures of BSL-3 containment, restricted entry. We have the biohazard symbols on that. And these are the N95 masks and the gloves which are to be used. Standard precautions, hand hygiene is to be followed. You have to wash with soap and water before, or use alcohol rub. Then wear gloves and PPE. Protective clothing, dedicated lab coat, gown has to be worn. Sharps have to never recap the needles. I already told, discard the sharps in a puncture-proof container. If there is any spill, you have to disinfect the work surfaces and deal with spills. And there should be, if there is any aerosol, so we don't have to use the wet mop, and never sweep or dust, so which resuspends the particles. So we have to use only a wet mop. Hand hygiene, again, before starting when to do the hand hygiene, before starting the work, before doing the aseptic, after exposure, after removing the glove, after touching the surroundings. Cough etiquette also, this I think Madam has told you, we should cover the cough and sneezes, mask the source, separate and fast track. So environmental controls. Ventilation, again, directional flow. And we all know the 5 moments of hand hygiene. So that I've already told you when to do the hand hygiene. The engineering control, ventilation, directional flow, biosafety cabinets, germicidal UVs, HEPA filtration, and disinfection. So air changes per hour also, this calculation has already been told. How do you calculate the number of times? What is air changes per hour? Is the number of times the entire volume of air in a room is replaced with fresh air in 1 hour. So this is the formula to calculate. And this also I have said, in the sputum collection area, we need to have more than 20 air changes per hour. In a TB laboratory, which in a general laboratory, we need to have more than 12 air changes. In a DRTB wards also, more than 12, ideally more than 15 air changes per hour. And in the ICU, we need to have more than 12 air changes per hour. So natural versus mechanical ventilation also, this has been told. And in the lab also, the same thing has to be followed. Directional flow, so it has to be, airflow should be from a hazardous to the less hazardous area. So coming to the biosafety cabinet, because this is related to the lab, I'll just tell you about what is a class 2 biosafety cabinet. It draws a curtain of inward air across the opening to protect the person who is doing it. And there are HEPA filters inside the biosafety cabinet which protect the sample. There are HEPA filters in the exhaust to protect the room and environment. And not you should never use a fume hood. A fume hood is one which only vents the TB live bacilli to the environment. So there are three types of cabinets: class 1, class 2, class 3. Class 1 is only protects the personal and environment because there is inward airflow, there is HEPA filter, but sample is not protected. It's a basic containment. Class 2, there is inward airflow plus HEPA downflow. There is HEPA filtered exhaust. And this is to be used in the standard TB culture and DST lab. And usually the class 2 cabinets which we use are the type A2 and B, which are commonly used. And class 3 is a fully sealed glove box. It works through attached gloves. This is used for most hazardous agents. It is not needed for TB work. It is needed for the very viruses which are very infectious. So biosafety cabinet, how to ensure that the biosafety, you are using good practices. You should run the cabinet 5 minutes before work at least 10 minutes, load everything before you start, move on slowly, decontaminate surface with 70% alcohol, and avoid is don't block the front of the cabinet, and do not use an open flame, don't overcrowd, don't treat the biosafety as a storage, and don't rely on a biosafety that is overdue for certification. This is very important. These biosafety cabinets have to be certified annually at least and calibrated. And this at least annually certification should be done, recertified when the cabinet is relocated or serviced, decontaminated and retest if there is any HEPA filter replacement, if alarms, airflow, drops or damage trigger. So this certification has to be done. Checks are very, very important. Centrifuge, I've told you we should do in a sealed centrifuge because if they are very highly infectious samples which we are using it, and our centrifuge tubes should be covered, and it should be done in a sealed container. The germicidal UVs also. What is a UVC? It emits 90% of their output at 254 nanometers. It damages the microbial DNA, RNA, and proteins, inactivating bacteria, viruses, and fungi. So Mycobacterium TB is highly susceptible. So GUV complements ventilation. So it is not a replacement for ventilation. So first we have to do the proper ventilation and then we can do the GUV. And there are just to tell you, there are three types of GUVs. First is the upper room GUVs, which Dr. Anita has already told you. There are in-duct GUVs, which are high intensity labs, which are inside the ventilation ducts. And they are invisible to the occupants. And what we use in the lab, they are the in-cabinet UVs. And it's a UV lamp which is decontaminates the surface. And this is to be used in the cabinet when it is empty. So before we start the work, we put on this GUV lamp, the person, and we close the sheet, the glass, the sheet of the biosafety cabinet. It should not be, the UV should not come out of the biosafety cabinet. So that is very important. So for empty cabinet only, as I told you, it is very important. It should be done only in an empty cabinet. What is GUV and why it is limited? Because it works only on surface and it does not penetrate materials. So never substitute wiping surfaces with 70% alcohol if we have a GUV, and remove items and wipe off surfaces with disinfectant and sash. This is what I was telling you. We have to close the sash of the biosafety cabinet when we are putting on the GUV, and clean the bulb weekly and replace the tube on schedule. And we have to ensure that this is working, because most of the times these bulbs are sometimes not working. So we have to ensure that it is working. So this is, I'll skip this. Safety limits again. This is, I think, then HEPA filters also used in the lab. They confer 99 to 97% safety. 0.3 microns are captured by the HEPA filter. And so inside every biosafety cabinet, there is a HEPA filter should be used. It should be used on the room exhaust, on recirculating systems, and they should be changed. Cleaning, disinfection, biomedical waste. This is also, I've already told you. Disposal of samples, put-on containers should be done in 5% phenol, autoclave, and then send it to the hospital biomedical waste route. Autoclave cultures and plates before disposal, segregate the biomedical waste, and hygiene. If there is a spill, it should be covered with disinfectant, and keep a stock TB spill kit within reach, hand hygiene, and report every breakage. So this also we all know. So I won't go. There are different yellow, red, and white and blue bins which are to be used. So TB lab rule is always decontaminate cultures and positive material, autoclave or 5% phenol before placing them in the yellow stream. Never send live bacilli to the waste. So these are the different things which have to be discarded. I think because of shortage of time, I will not go into these details of biomedical waste. And this is also managing a spill. If a spill occurs, what is this? I'll just go in short. What should be done? First, you have to hold your breath and leave that area, evacuate, let the aerosol settle, close the door, then gown up, return, re-enter in a fit tested N95, wear the gloves and gown, and then re-enter. Then cover the spill with absorbent disinfectant layer. Wipe towards the center, discard into the biomedical waste, and then disinfectant. And then log the incident and record it. Respiratory protection, also this has been covered by Anita madam, but in the lab also we use this triple layer masks. So this also you have to do the fit testing, the positive pressure check, negative pressure check, because if the N95 mask is not effective, there is any leak, so it is useless. So it has to be checked. We cannot use the mask if it is not functioning properly. So donning and doffing also we know this. Just to tell you what is the steps. First we do the hand hygiene, then we wear the gown, then we use the N95 mask. We check the seal, we wear the goggles and gloves, and then when we do the doffing, we do the reverse. We remove the gloves first, then the goggles, then the gown, then the hand hygiene, and N95 is the last. So healthcare worker surveillance, the baseline, whenever this is important, whenever a new person joins, we have to screen every new staff member for TB disease and infection. Periodic screening has to be done, health checkups, facility level, compile the TB among staff data annually, and a cluster of staff cases if is a signal, and then you have to investigate. Training and capacity building is very important. Induction training, annual refreshers, assess competency, monitoring evaluation. The Hospital Infection Control Committee also, the rules and reviews. This is important, the AIC gaps in the TB labs. So I'll be only covering the important things because, so the windows should not be locked or shut. Second, uncertified cabinets should not be used. Masks used as respirators should be fit tested. The neglected germicidal UVs, if they are dusty, they are not maintained, then they should not be used. Mechanical ventilation, if there is no power backup, GUV failed during frequent power cuts that has to be seen, and there has to be an effective AIC plan that exists in the, not only in a file, but in daily practice. Usually what we do is we just put it in the file, we say we'll do all these things, but it is not done in practice. So we need to run a AIC self-check checklist. Inside the TB laboratory, no indoor sputum collection, work near the flame, daily batch decontamination, 5% phenol and respiratory, and right lab, culture DST and molecular lab should follow the NTP laboratory biosafety manual and this thing. So just summarizing and just a few carrying on messages. The TB lab is the highest risk setting. Work the hierarchy in order, administrative first, then environmental, contain at source, certified class 2 biosafety cabinet, sealed centrifuge, verify your air changes per hour target, GUVs or HEPA filters, and certified cabinets, fit test respirators, screen staff and monitor controls. This is the key references. So these are the references which were used. The National TB Guidelines 2026, Biosafety Manual 2023, Guidelines on Airborne Infection Control, the WHO Global Technical Consultation. So these were the references. So thank you and for the patient listening. And
Thank you very much, Dr. Manda, for your insightful and informative presentation. Actually, this laboratory biosafety and the GVs might be a very noble topic for nurses other than who are working in the TB hospitals. I hope this was quite informative and a new topic for you. Now, before moving to the next speaker, I again request all the participants to please post their queries in the chat box so that when the question answer session comes, we'll take that questions one by one. Okay, please, after this presentation, you can put your queries in the chat box and then go to the another presentation. Thank you. Our next distinguished speaker is Dr. Gyan Shankar Mishra. Dr. Very good afternoon, sir. Warm greetings. Dr. Gyan Shankar Mishra. Very good afternoon. Are you there, sir? Am I audible? Dr. Mishra, am I audible?
Yes, audible.
Before, I would like to introduce you to all the participants here with us. Dr. Gyan Shankar Mishra is an associate professor in the Department of Respiratory Medicine at Indira Gandhi Government Medical College, Nagpur. He serves as a nodal officer for the District Drug Resistant TB Center under the National TB Elimination Program, NTEP. He is a member of the NTB Transmission Initiative, ETTI, core working group of the Stop TB Partnership, and has extensive experience in tuberculosis care, airborne infection prevention and control, and operational research. Sir's topic of presentation is certifying a tuberculosis patient as non-infectious under Indian guidelines and practical considerations. A very good afternoon, sir. On to you.
Good afternoon. For the kind introduction. Am I audible clearly?
Yes, sir, you are quite audible.
yes.
So right now we are having heavy rains in Nagpur. So greetings from Nagpur. And after the two main sessions, first was on administrative control and next was on lab norms. We'll be moving to a more of clinical topic, that is certifying a TB patient as non-infectious. What are the current Indian guidelines and practical considerations? Yeah. So why is this topic important? The question that we are asked almost every day in our OPD by the patients mostly is that, doctor, when am I non-infectious anymore? So day in and day out, we see TB patients and the patient has a lot to think about. The employer asks for fitness certificate from the patient. The schools ask when the child can return. The healthcare workers returning to duty have their own issues. The risk to the other healthcare workers. Then again, if the patient declares that he has TB, then airline and travel clearance is required from non-infectious point of view. The family members of the patients, they are worried what will be the risk to the family members. And above all these contribute to social stigma and misunderstanding. So there is a lot of psychological stress on the patient. And the patient finally comes to us with a question, doctor, when am I not infectious anymore? So NTP guidance was needed on this, and the main reasons why the NTP guidance was needed because we did not have an objective criteria to certify non-infectiousness till almost last year. The patient had issues related to social stigma, job loss, or delayed return to schools, and the treating physician had to answer to the employers or the schools and colleges when the patient could return. The family, of course, again asked the treating physician, is it safe to live together? So in absence of any uniform guidance, it was very difficult for the patient to, for the physician to certify these things. So before 2025, we did not have any concrete guidance. However, last year, we did have some guidance and it was of great help. However, these guidance are not much percolated since the last year. And what this guidance has helped is making it standardized. The criteria for certification of non-infectiousness. So last year on 30th May 2025, the Central TB Division came up with this guidance document as to when we can certify a patient with TB as non-infective. So before going to the proper guidelines, we need to understand that what are the factors that determine the TB infectiousness. So there are basically three factors. One is related to the source, then environment, and then recipient. So the most important factors are related to the source of the patient, like the bacillary load. If the bacillary load is quite high, then that almost converts to a higher infectiousness. So again, if the patient is more symptomatic, he has more cough frequency, then more aerosol generation will be there, and again the patient will be more infectious. If the patient has smear or culture positivity, then again the likelihood of transmission of TB bacilli are high. The next important factor is effective treatment. So if remember the word effective treatment. So appropriate regimen reduces the bacillary load. However, if the treatment is not effective, the bacillary load will not be increased. It will not be decreased. Then after giving effective treatment, the patient has to adhere and comply to the treatment because effective treatment becomes successful only when the patient takes it. Then there is clinical improvement. This is very important. There has to be signs of clinical improvement. Then the patient will be relatively less infective. And finally, we need to have a look at the radiological response. Other than the source, environmental and recipient factors are also there. Like the environment factors, as already detailed in the previous presentations, we require a good ventilation. And a good ventilation will reduce the concentration of droplet nuclei. There has to be less crowding. The duration of exposure between the patient and the contacts, that has to be less. So the more the duration of exposure, the more infectiousness. The lesser the duration of exposure, the lesser risk will be there. Again, airflow and air circulation, they are an important factor. We need to understand that recirculation increases the risk. So in closed environments where there is recirculation of the same air again and again, that will increase the risk of transmission. And then again, respiratory protection or PPEs. The patient is usually supposed to wear surgical mask, and the contacts or the healthcare workers who are treating them, they need to wear the N95 mask. Then coming to recipient factors, any factor in the recipient which leads to a decreased immunity, like HIV infection, diabetes, immunocompromised states, the patient may be on long-term steroids, the patient may be elderly, there may be comorbidities. While certifying, we need to factor in all these things. But the most important factor that we need to consider is the source factor. The environment and recipients, they are not directly related in certification, but the source or the patient factor, that is the very important factor which we need to consider in while declaring the patient as non-infectious. So infectiousness is multifactorial, but effective treatment, adherence, smear conversion, clinical improvement, along with no evidence of clinical or radiological deterioration are key to declaring a TB patient as non-infectious. So the message that we can take from these slides are that infectiousness decreases effective treatment. This is very important. The earlier and better the treatment, the faster the risk of transmission falls. So, so it is not important that the patient takes the treatment. It is important that the patient takes correct and effective treatment. So a correct and effective treatment will decrease the bacillary load. It will lead to improvement in the symptoms. Or symptom improvement will lead to decreased cough frequency. It will lead to an earlier sputum conversion. And above all, if the patient is adherent to this treatment, then finally the patient can convert into a non-infectious state. So adherence to treatment and practice of AIC measures, as outlined previously, are important and in reducing the risk of transmission. Now again, coming to the point of effective anti-TB treatment, the NTP guidelines, they focus on the programmatic treatment. So they take into consideration that a patient is having an effective treatment under the program. However, if a patient comes to us outside the program, we need to be aware that a significant errors could be there in the prescription. So this was one of the studies that was done recently by our group, and this was the Praman India study. This is the first study which has quantified the TB prescription practices outside the program. And to a surprise, we found that almost half of the prescriptions had some error in them. So incorrect prescription chances are quite high if the patient has received a non-programmatic treatment. And therefore, the certifying physician needs to be aware that if the patient has taken a non-programmatic treatment, he should just judiciously check the prescriptions and for any possible errors. And if there are errors, then the duration of treatment, of effective treatment, that should be counted. Like supposing if a patient has taken an incorrect treatment, then that duration of treatment should not be counted for certifying non-infectiousness. The treatment should be corrected, and from the date the treatment has been corrected, that treatment should be counted for correct duration. So correct prescription leads to effective treatment that will lead to decline in infectiousness and reduce transmission. Those who are interested, they can scan this QR code and they can have a look at this the project results in detail. And I'm pleased to share the news that just a few hours back we received the acceptance of this study in Indian Journal of Tuberculosis today itself. So this will soon be published in the Indian Journal of Tuberculosis. Coming to the 2024 guidelines. So before our Indian guidelines came in the year 2024, the NTCA guidelines for respiratory isolation and restriction to reduce the transmission of pulmonary TB in community settings was released by the NTCA, which are the American guidelines. So the important point in those guidelines was that there is no single test which accurately predicts infectiousness, be it smear, culture, or NAT. So over-reliance on a test was not recommended. What they found was an alarming fact that 5 days of effective treatment, irrespective of sputum smear or culture status, dramatically decreases the infectious potential. So this was a very important finding in the 2024 NTCA guidelines. And therefore, they recommended that the decisions of isolation, de-isolation, or certifying non-infective a TB patient should be based on initial bacillary burden, drug susceptibility and regime effectiveness, treatment adherence, clinical response, and risk of exposure to vulnerable population. That means the host, if he is a susceptible host. They have very nicely depicted in the figures. If you can see the right-hand top figure, here you can see, in the top you can see that after 5 days of duration, almost maximum the infectiousness is decreased. The dark green color, that signifies lowest infectiousness, and light green or white color, it signifies highest infectiousness. So you can see that if the bacillary burden is low, then after 5 days of effective treatment, the infectiousness is the lowest. Similarly, the transmission risk, you can go see the bottom figure. There it shows that the transmission risk is the highest when the individual infectiousness is high along with prolonged exposure. So prolonged exposure or decreased exposure and effective treatment duration, these two are the factors that will determine the infectiousness. So in most of the times, effective treatment, it leads to decreased infectiousness in almost 5 days. But in the top figure, you can again see that after 14 days, even in high bacillary burden cases, it is totally green. From top to bottom, it is dark green. So that means the infectiousness potential is days. So TP guidelines, they have almost based on this, they have given us the criteria. So we'll just see the NTP criteria. So coming to the gist of today's lecture, this is the most important slide of the presentation. The NTP in 2025, they have come out with this criteria to certify a TB patient as non-infectiousness. Now there are 3 important parameters. the clinical and radiological requirements, the lab requirement and treatment duration, and all this depend on the type of TB. So the clinical and radiological requirement, they are the same for all types of TB. There has to be clinical improvement and there has to be no evidence of radiological deterioration. So I'll repeat this. There has to be clinical improvement and there has to be no radiological deterioration irrespective of the type of TB. Coming to the lab requirement, they have made it very simple that for drug sensitive TB or H monoresistant TB, you need to have 2 smear negative reports 7 days apart. And for drug resistant TB, you need to have 3 smear negative reports 7 days apart. That means if I have a report in the 7th week, then I need to have a report in the 8th week, then in the 9th week, and all these 3 reports needs to be negative. And then coming to the most important factor, that is treatment duration of effective treatment. So if it is a drug sensitive TB or H monoresistant TB, the patient should take a minimum of 2 to 3 weeks of treatment. If it is drug sensitive TB or H mono TB, where it is an extensive and cavitary disease, that means if it is lots of cavities are there, it is bilateral extensive, then there 4 to 5 weeks of regular treatment are recommended. And if it is DRTB on shorter regime like BPALM, then 9 weeks of treatment duration is recommended. And if it is DRTB on conventional all or longer regime, then minimum of 3 months of regular treatment is required. So I'll again repeat the treatment duration. If it is drug sensitive TB or INH mono resistant TB, and that has to be non-extensive, then 2 to 3 weeks of regular treatment is required before certifying. If it is DSTB or H mono resistant TB, then 4 to 5 weeks of regular adherent treatment is required. If it is DRTB on BPALM or shorter regime, then 9 weeks, and DRTB on all or longer regime, then 3 months of treatment is required. Before this, the patient should not be certified. So the practical algorithm, it goes something like this, that a patient comes to our OPD, we need to confirm that the patient is on treatment. The next point we need to confirm is that the patient is receiving the correct treatment. The third point we need to confirm is that in the event that the patient is receiving a correct treatment, the patient is adherent to it. Fourth, the patient needs to report clinical improvement, cough, fever, increased weight, no clinical worsening. Fifth point, there has to be a lab evidence in the form of sputum conversion. Then there has to be no evidence of radiological deterioration. So only after all these 6 points are fulfilled, then a certificate can be issued. Now again, this is important that once a certificate has been issued, the guidelines again say that post-certification follow-up is also important, and that is extremely important. The patient needs to be in this post-treatment follow-up phase, the patient post-certification follow-up phase, the patient needs to be adherent to the treatment. Cough etiquettes have to be maintained by the patient. The patient needs to have good nutritious food, and long-term monitoring of the patient is required, not only during the treatment, but also after the treatment. That means after the patient has completed the treatment, the patient needs to come for follow-up every 6 months for the next 2 years. Now coming to some common clinical scenarios. So these are some scenarios that we might face in our OPDs. The first scenario is that the patient feels well, but smear is positive. So this is a very common scenario. The patient is very eager to get a non-infective certificate, and due to that, the patient sometimes says that I do not have any symptoms, even though the patient might be having symptoms. So in this case, you need to have a look at objective parameters like weight gain, also, and clinical and radiological parameters also. And if the symptom is the smear conversion has not occurred, then you need to continue the treatment and wait till the smear conversion has occurred. The next point is patient is smear negative but is not adherent to the treatment. So in this case, we need to improve the adherence first, counsel the patient, ensure that adherence is there, and only then after the certification criteria have been met, issue the certificate. Number 3 is MDR TB patient. He has come after 6 weeks. So let's consider that this patient is on BPAL-M and the patient has come to us after 6 weeks. So what we can do is we can do a clinical evaluation and start smear examination at the end of 7th, 8th, and 9th week. So if 3 consecutive 7th, 8th, and 9th week are negative, then at the end of 9 weeks, the patient will fulfill the criteria of being non-infective. Then coming to school certificates and employer certificates, we need to write clearly on the certificates that the patient is non-infectious. And in case of employment certificate, we need to understand that fit to resume work and non-infectious are 2 different things. Non-infectiousness is just the infectivity of the patient, and fit to resume work, for that one of the criteria is non-infectiousness, And the other criteria are depending on the type of work that the patient has to do. So we need to inquire what type of work the patient has to do and whether in his current condition will he be able to continue that work or not. So coming to the end of this session, the take-home messages that I would like to point out from this session is that infectiousness decreases with effective treatment. Each and every word of this is important. The infectivity will decrease only if the treatment is effective. Okay. So if the patient is not taking a correct treatment, infectivity will not decrease. You might get a smear conversion, but that could be due to the fall and rise. And after the smear conversion, again, a reversion could occur. So you need to double check whether the patient is receiving an effective treatment or not. Certification should now be based on NTP criteria that we have just shown. And adherence, cough hygiene, and good nutrition are equally mandatory. The patient should not be negligent after a certificate being issued that okay, now no precautions have to be made. So patient needs to understand that adherence to the treatment, cough hygiene, and good nutrition are equally important. We while issuing a certificate, we need to follow a stepwise approach as already shown. The patient safety and public health come first. So never issue a non-effective certificate under any kind of pressure. Always follow the medical guidelines. So therefore, we can say that effective treatment, adherence to the treatment, smear conversion, and no radiological deterioration will fulfill the safe certification as per the NTP guidelines of 2025. So this is a AT website. You can search on the Google and you can visit this website. There are plenty of resources on this. And this 2025 guidance we have also uploaded on the website. So you can go through the guidance document from the website. And this was the national guidelines that Grigory was referring to in the initial address. The national guidelines on the prevention and control of airborne infection, including TB, has been released this year in March 2026. So I encourage all of you to please go and read these guidelines. These are extremely detailed guidelines and very useful. And this is just a QR code. If those who are interested, they can scan the code and join the AT newsletter for free. So thank you. If there are any questions, you can take in the question answer session now.
Thank you very much, sir, for your insightful and informative presentation. All the sessions have been covered and done, and now we will now open for the floor for this question answer session. You can, if you have any queries related to any of the topics covered by the speaker, you can put in the chat box. It's already there. So we'll now open the chat box first and read the question answers.
I think there are some questions for Dr. Gyan Shankar only, the related to infectiousness at the end. And there are, related to the lab, I'll just go later on. So I think first you can answer, sir.
Yes. So one of the questions is DRTB cases. This is asked by Dr. Indranath Roy. In DRTB cases, smear could be negative, but culture might show positivity. So please opine what will be done to issue a certificate. So usually in DRTB cases, this scenario was imagined by the TB experts. So therefore, they have given a rigorous criteria of smear negativity, and that too after 3 months of effective treatment. Now, we need to remember that the culture reports are usually available to us by the end of 42 days, and they take a long time. So supposing at the end of, supposing if the culture conversion has not occurred, then the clinician can use his judgment and withhold the non-infective certificate. So an important parameter in issuing of certificates is again clinical judgment. If you have a report of positive culture despite a smear being negative, you can still withhold the certificate. Then one question is, if a child having pulmonary TB coughs rarely, can we call him as negligible source of transmission of MTB? Yes, coughing is the primary mode of disposal or primary mode of transmission of pulmonary TB. So if cough is not there, that means the patient may be responding to treatment that could be there, and the transmission risk will be less than a person who is having a more cough or more cough frequency. So in studies also, and in the 2024 the NTCA guidelines also, they have clearly said that the increased cough frequency is a high risk factor for transmission of MTB. Then one question is, the AB sputum smear microscopy has to be done from NTP lab or any private lab for certifying non-infectiousness. So the NTP considers accredited labs only. So if under the NTP guidance, it is preferable that it should be from an NTP accredited lab. And again, while certifying based on smear microscopy, I would like to point out a couple of points. It's not just the negativity that you need to see. You need to see what is the quality of sputum. Supposing if there's two sputum smear negative, but both of them are salivary samples, so you need to discard that report. So you need to think, you need to interpret everything in the correct clinical perspective. Again, okay, one question is TB lymphadenitis lesions are not resolved after complete treatment, even in DSTB. Confirmed. How to ensure complete treatment or cure? So regarding TB lymphadenitis, I would like to request everyone to go through the ICMR guidelines. Now, this TB lymphadenitis is the only condition where the ICMR has recommended one investigation called the therapeutic drug monitoring. So in case the clinician suspects that this is a non-response and other causes being ruled out, like adherence, compliance issues, drug resistance, everything being ruled out, then you need to rule out subtherapeutic drug levels also. And again, after everything has been ruled out, if the lesions are not resolved, you need to compare the lesions with the baseline. So after completing the duration of treatment, if the lesion has not increased, the lesions are static, or even if they are decreased, then you can give the outcome as treatment completed. In absence of microbiological reports, the outcome has to be given treatment completed and not cured. Okay. One again question is, if a DSTB patient comes up with cured as a final outcome, then during post-treatment follow-up, can triage be still implemented as a source of control measure in hospital? No, usually after cure, if the patient is just coming for follow-up, then it is not there. But if the patient is symptomatic, then of course triage will be there, because during the 2 years period, one of the aims of follow-up is to detect relapse. So if the patient becomes symptomatic, then he should again be put on the triage. But if the patient is completely non-symptomatic, then it cannot be done. So in the triage, 10S symptom screening needs to be done as per the new guidelines. Okay, one question is, one patient having TB seen in 2020 after completing treatment, then clear, and then again after 1 year start treatment again, is still now patient taken 6th time, then what to do? Okay, so probably here the question being asked is that in 2020 the patient had TB, and after that again recurrent treatments, recurrent TB diagnosis are being made. So in such cases, if you have relapses or frequent relapses, you need to first confirm that whether it is TB or not. If the relapses are, whether you are diagnosing relapses only on clinical basis or microbiological basis. Supposing if it is made on microbiological basis, then you need to see whether the AB smear is positive or not. And again, go for CB-NAT. Some of the causes are that of recurrent relapses. One cause is that the patient would not have taken the treatment correctly. Another cause is there is an undiagnosed index case in the house. Another cause is there could be co-infection with NTMs. So you need to have a look at all these conditions and take a detailed history and evaluation of the patient. Okay, so if the sputum is negative but X-ray test is suggestive of cough and long-standing cough is present, whether to start the treatment or not. So under the NTP guidelines, under the algorithm, there is a provision of clinically diagnosed pulmonary TB, and you can label it as clinically diagnosed pulmonary TB, provided it fulfills the criteria. If follow-up sputum culture smear shows negative, but there is no clinical improvement, can we call it infection? No. So clinical improvement is also required. It is one of the parameters. So the last parameter was clinical improvement or no radical deterioration. So that has to be there. Only when all the parameters are fulfilled, then only a non-infectious certificate has to be issued. Okay, so I am able to see these many questions.
Yes, sir. Thank you, sir. Thank you, Dr. Gyan Shankar. And I think from the lab there are only one or two questions, and it has been also partly answered. The first question was how do you dispose the sputum containers in the DMC? So it was just like to slightly elaborate. So that sputum container, we should open the lid of the container, and it has to be dipped in a container with 5% phenol. It should not be directly put in the container. It has to be, the lid has to be open and not hypochlorite. It has to be in 5% phenol. And after this, and if autoclave is available, preferably you can autoclave, but otherwise after phenol, overnight disinfection, we can put it in the yellow bin as an infectious waste. And secondly was about the donning and doffing. They said that if we need to use shoe covers and included, then what is the sequence? So for donning, first you have to do the hand hygiene, then wear the shoe covers, then wear the gown, then mask, then the eye shield or goggles, and lastly the gloves. And for doffing, the principle is that to remove the most contaminated item first. So while doffing, you have to remove the gloves first, then the gown, then the goggles, then the mask, then the shoe covers, and lastly do the hand hygiene. So these were the two questions which I could see. And for germicidal UVs also, I think, sir, you answered the question that dust makes it ineffective. The cleaning is recommended every 3 months. The GUVs have to be cleaned, and the AMC also should be done. And if there is any renovation work or cleaning done, then again, renovation work done, then cleaning has to be done. The life of a lamp is 9,000 hours, so tube has to be changed after that. So that was from our side. Any other? Anyone else has any other questions from the audience? So if there are no questions, then I think, Seema, we can.
Most of the questions have already been answered, so we are not taking it here.
Yes, so already been answered in the chat.
We have a lot of constraint of time also. So thank you. Thank you. We value your participation, and all your questions which you have asked, I suppose they have benefited other participants also who will join this session. With this, we conclude today's webinar. Thank you once again to our distinguished speakers and all the participants for making this session meaningful and interactive. We look forward to welcome you to the future programs. Have a pleasant day and thank you.
Thank you, Grigory. Thank you, Dr. Grigory, Dr. Gyan Shankar, and all the dignitaries and participants for attending this. I hope it was a useful session. And we look forward to more sessions in future. Thank you.
It was exceptional. Thank you so much. I learned a lot myself. So India is progressing. Congratulations.
Thank you.
Thank you. Thank you.
Thank you.